a, ver a variety of emerging infectious diseases that I want you all to know about. Some of them are relevant to biocontainment units, but some are not. But either way, as all of you participating as regional leaders in emerging infectious diseases, these are things you should know about, watch out for, and be able to speak to because you are looked to as subject matter experts in the management of these infections. And we'll talk a bit of the more global impact of these emerging infections on global health preparedness and frontline response. So, when you look at crude mortality rates for all non-infectious and infectious diseases causes, now this is old and it precedes the pandemic, but you can see we've made a lot of progress in mortality rates for infectious diseases. And so much so that there's actually a time when our U.S. Surgeon General testified that it was time to close the book on infectious diseases and that we should focus our research in other areas of public health. Well, we know that the war is not over against infectious diseases. And over the past century, and very recently, we have had a lot of issues with emerging infectious diseases. Overall, in the previous slide I have shown, and now coming down in a post-COVID era, we have seen a decrease in infectious diseases as a cause of death in this country. And that's largely because of improved sanitation, vaccination, antibiotics, all of that have played a big role in this decrease. But in the past 20 years, the incidence of emerging infections has increased, and we have seen examples in the recent past few years with COVID, how a large pandemic event can completely shift that curve. So we're going to have to be dealing with it. We can't say, okay, we're done. We had COVID. We are out of the woods for a while because this is going to be a perpetual challenge. We have the constant balance of having to circumvent human interventions and public health measures with biomedical research, tech advances, but we're up against the ability of microbes and viruses to rapidly replicate and mutate, and constantly having that ability against all of our best intentions and science. These microbes have the ability to get around that. So, what are some examples? Well, this slide lists too many examples of emerging and re-emerging infectious diseases, too many to talk about in this hour. So I'm going to go over some just general categories of emerging and re-emerging infectious diseases that I think are the biggest threats right now. So again, some of the factors that contribute to these emerging infections is just population growth, especially in certain areas of the world where people live more closely together than perhaps they would in areas like the United States. We have the ability to travel, and our speed and access to international travel has increased. We import food and transport food, animal and vegetable products all around the world. And we process food and handle those products in a way that puts a lot of risk for widespread transmission of infections through that process. We also, as the population grows, encroach on habitat that puts us in closer contact to insects and animals that harbor new infectious diseases, and allow for that ability to jump a virus or something else to jump from an animal reservoir to human. We have the issue of antimicrobial resistance and a breakdown in public health infrastructure in many areas of the world and potentially in the United States. So this is a pre-pandemic list from 2019, but even before the COVID pandemic, infectious diseases dominated the World Health Organization's list of health threats, including global influenza pandemics, Ebola, and other high threat pathogens. Vaccine hesitancy was identified then as an issue, dengue, as well as HIV. So I'm just going to start with addressing the flu. And sometimes I think we forget that this is still out there. Again, with COVID, I think that threw a loop in our preparedness plans in terms of just thinking, what is the likely respiratory virus? There had been so much focus on flu, and then a coronavirus comes along. Well, flu is still out there, and this slide reminds us that it has a history of emerging and reemerging, starting with the 1889 Asiatic or Russian flu on this slide. And then what doesn't even fit on this slide is the impact of the 1918 Spanish flu, which was an H1N1 strain. We saw that later emerge in 2009, but with much less impact. In between then, we've experienced the Asian flu and Hong Kong flu in the late 50s, late 60s, and have had the threat of various bird flu viruses emerge in the interim. So we have to continue to keep a watchful eye. And why is that? Well, it's this concept of shift and drift. We have something called antigenic drift, which basically are just these mild changes in proteins, these small changes in proteins by point mutations that are the reason we need to update the vaccine every year. And then there's antigenic shift, which are bigger changes in the proteins through genetic reassortment. And that is what produces the potential of viruses never seen by humans and not covered by vaccine to spread rampantly through a population. And here's an illustration of what that looks like. On here, you'll see a variety of animals. You see some birds, you see a pig, but the concept is often that these viruses may be housed in a bird or a bat. In this model, an animal will be infected with potentially a human virus as well as a bird virus. Those two viruses can swap genetic material. In other words, have a reassortment event where a new virus with features of both a human and a bird flu virus could come together and potentially have an avian human pandemic reassortment virus. And so this is what we watch for. This is some of the issue with the bird flu that we have been hearing about. The strains can be different. It can be an H7N5, it can be an H5N1, but the bottom line is there's a virus produced that humans are very naive to. We know this can happen because of some science around the 1918 virus reconstruction that shows an entirely avian lineage. There are reports of flu outbreaks in poultry that have illness in humans that live and work in close proximity to those flocks. Recently, we have the same kind of events occurring in humans with proximity to cattle. And so these variants can spread and produce a high mortality rate. The one caveat I would give is that often when these initially reemerge, the human to human spread is less of an issue, that they're not very efficient spreaders from human to human, but they do carry often a high mortality when they do infect a human. So there has been some recent activity with some of these avian influenza viruses infecting humans as of late. And this is actually a slide that was updated in early September of this year. With a total number of cases of 70, with I think one death in the United States. And Colorado was one state that had a fair number of infections reported. And this in Colorado, there was also a case of a poultry worker in 2022. But Louisiana reported the first H5 bird flu death in a human in the US. So the exposure is related largely to livestock and maybe some backyard flocks, other animals, but it's out there. So we need to keep our eyes on this. This is a New England Journal publication from the very beginning of this year that reported some findings on avian influenza. Now, in this case, this particular H5 caused very mild illness, mostly conjunctivitis, short duration. The exposure was infected animals. Most the patients who were affected in this report had prompt antiviral treatment. There was no evidence of human to human transmission in these recent events. And as noted, and again, something that may be seeking expertise of our regional leaders is that PPE use among these occupationally exposed was really suboptimal. And so we'll need to think about some strategies to reduce risk among people who aren't as familiar with PPE use. So another telling a cover feature, shifting gears a bit. This is from Time some years ago. Revenge of the Killer Microbe. So, in contrast to Dr. William Stewart's statement that we can close the book on infectious diseases, fast forward some decades, are we losing the war against infectious diseases? So, what they were referring to in this Time cover article was the impact of antibiotic resistance and the concern that although we have all these therapies, we're now seeing emergence of common bacteria becoming resistant to many of the antibiotics we used. So why do we care about that? Well, intuitively, yeah, we need to have a treatment for it, but there has been association with antibiotic resistance with increased morbidity and mortality, increased length of hospitalization, and increase in hospital costs. So some of the threats out there have been changing in their prevalence. These are data from 2019 to 2022. It seemed that the pandemic impacted some of these more common bacterial infections and spread that we saw in hospitals. So remember a time when our biggest worry was MRSA. Well, it seems that we did put a lot of attention to MRSA, and many of us in hospitals enacted measures to reduce spread in hospitals. We then had an advance in drug development of MRSA and developing protocols for screening, decolonization, etc. So with MRSA, we started to see a decrease and now a stable rate of hospital onset MRSA. VRE, similarly, though maybe increasing slightly, we are seeing more Enterobacter producing Enterobacteriaceae and multi-drug resistant Pseudomonas after experiencing a little bit of stability during the pandemic. But something that has emerged and has just been increasing for years is fungal infection. Candida auris has been a clinical concern, particularly overseas, but certainly the United States has seen plenty of this in patients with the emergence of a common fungal that lives on our skin that has the potential to cause an infection now resistant to all the antifungals we have available and traditionally used for Candida infections. Carbapenem-resistant Acinetobacter has also been on the rise, and hospital onset carbapenem-resistant Enterobacteriaceae. Just for level setting, the Enterobacteriaceae are include your organisms like E. coli, the most commonly identified etiology of infections in healthcare settings because it commonly causes infections like urinary tract infections. So going back to the Candida auris issue, this was first identified in 2009 in Japan and has been some of the earliest strains probably date back to 1996 in South Korea. So this has caused bloodstream infections, wound infections, ear infections. It's been isolated from respiratory and urine. And the risk factors are what you would expect for other types of Candida infections. And typically we can't just pull out our fluconazole. We have to look to other agents for the treatment of this infection. So same with carbapenem-resistant Enterobacteriaceae. We've had issues with this really identified since 2001. And the problem is, again, these are bacteria found in our GI tract. It's the most, they comprise the most common cause of the most common infection we see in healthcare, which is UTIs. They have this enzyme that can make these common bacteria resistant to most of the drugs available for treatment. And that non-susceptible characteristic has a number of different mechanisms for allowing that resistance. But one of concern in hospitals is these plasmids that not only can bacteria spread from person to person, spread of the bacteria itself, but even just the plasmids can jump and then affect other types of bacteria. So it is something we need to be aware of and conscious of in our infection control programs in our healthcare settings and beyond. So here's another one that we got to watch out for. Imagine a world where we can't treat gonorrhea anymore. That would not be a good world. So this is something, even though the rates are very low, once you hit a certain threshold of resistance, you need to watch very closely because there's sort of a tipping point where once you be into the double-digit resistance rates, that it just amplifies like wildfire. So this is some data from the gonococcal isolate surveillance project back in 2022. And it describes different resistance profiles for different antimicrobials. And what is striking about this is the rate of resistance we're starting to see in gonorrhea isolates to multiple antibiotics. So another thing to watch as we think about our challenges with antimicrobial resistance. Okay, shifting gears again. I'm sorry about the blurriness of this slide. It did not cut and paste well from another slide I had. I wanted to talk a little bit about some of the hemorrhagic fevers and the ongoing outbreaks. And so I'll just give a little background. There are a lot of hemorrhagic fevers out there, and it's really, the differences between them are subtle and may not be obvious. The difference between uh, Ebola versus Chapare or whatever other hemorrhagic fever type. It really is an epidemiologic distinction that's most relevant here. The clinical presentation, though may vary slightly, generally is one that's very flu-like. Fever, loss of appetite, weakness, headache, myalgias, maybe diarrhea, stomach pain, rash. And as these infections progress, you'll start seeing other symptoms such as vomiting and maybe bleeding that can present as bloody diarrhea or sometimes bruising, bleeding from the nose or gums. But that is usually the rarest presentation. Typically, what you'll see is these non-specific presentations. And that's what makes this challenging. It's not obvious. And remember the experience from Dallas when we had a patient present to a hospital there with Ebola. He presented largely with these early symptoms and some diarrhea, and it eluded the clinical diagnosis. So again, hemorrhagic fevers, there are so many, and really, and they all have different vectors or animals or insects that spread it. And I provide this here on this slide taken from the CDC. There are certain parts of the world that house these viruses based on the vector that carries them. So I'll keep this here for your information. And I haven't memorized this, and I don't know that you need to either. But know about some of the key ones that are spreading now. So Ebola is still out there, and there have been a number of outbreaks by species and size since 1976. Probably the most memorable in recent history is the one we experienced in 2014, where we did have some presentations in the United States and confirmed cases here in the United States. But these spread of Ebola continues in different parts of the world, and one that we're hearing about now is in the Congo. This is a report from early September. Their Ministry of Public Health officially declared an outbreak of Ebola in Bulape and Mweka health zones in one of the in the Kasai province of the Congo. And this is not rare. This is a 16th outbreak they've experienced since the virus was first discovered. And as of September 15th, there are 37 people with confirmed Ebola and 19 deaths, including 4 healthcare workers. So keep an eye on this. We know that these things can spread and not only locally, but as always, infectious diseases don't obey borders. So something to keep attuned to. The other one I want to mention is Marburg virus. We recently had a big outbreak in Rwanda last year with 66 cases and a high case fatality rate of over 20%. But this was not the only outbreak. The year before that was Tanzania and Guinea, and then Ghana before that, and Uganda. So there have been a number of cases since its description in 1967, and we have to keep an eye out for Marburg as well. And just a little background, what is Marburg? Well, it is one of the hemorrhagic fevers that is classified in the filovirus family. It is housed in the Egyptian rosette bat. And like many hemorrhagic fevers, they do have a bat reservoir. And again, it was discovered in the late 60s in Frankfurt, Germany, in Marburg and Frankfurt, actually. And then also cases in Yugoslavia, which is now Serbia, after exposure to African green monkeys. And so this is one that continues to make the news and something that has spread to the US, and we need to keep an eye on as well. So I'm going to shift now to some of the novel coronaviruses. I'm going to start with the little graphic that is on the left side of your screen. And what this is kind of a family tree of coronavirus. And where I have stars are is where we see human infections of coronavirus that make up basically the common cold. And since I've been adding to this slide over my career, where after, those six typical common cold coronaviruses, we've seen emergence of other coronaviruses that have caused pandemics. The first, SARS-CoV-1, which resulted in the SARS outbreak in Toronto. And then we had the MERS outbreak with the human coronavirus EMC, which stands for Erasmus Medical Center, where it was first identified in Saudi Arabia. And then, of course, SARS-2 or the SARS-CoV coronavirus or the COVID-19 virus has also since emerged um, when the slide was made. So these viruses are closely related, but it shows you that coronaviruses are just very ubiquitous as a cause of upper respiratory tract infections in humans. And I think will always be potential to have another coronavirus emerge, just like flu, through these different reassortment events or other exposures. So I'll take you to the graphic on the right, which shows where we often see coronaviruses emerge from a bat reservoir. And there's all kinds of different theories about how those coronaviruses found in bats that then seem to find an intermediary host with SARS-CoV-1 thought to be the civet cat or the raccoon dog, which was they were especially prevalent in the live animal markets in China, where you have a lot of close proximity to humans and those animals. You get that zoonotic infection, and then it manifests in a human. In the case of Middle East respiratory syndrome, it was thought because of the location in the world that it really was quite confined to the Middle East. Of course, the logical place to look is in the camels, and there was some documentation of potential cross-species transmission would result in zoonotic transmission to humans. So, for the most part, at least in Saudi Arabia and with SARS-1 in Toronto, was a it was primarily nosocomial, so healthcare transmission, and most of the spread, as well as the deaths, were in healthcare settings. Now, what's interesting with SARS-CoV-1 in other parts of the world, like Singapore, where they had a big outbreak, and other parts of Southeast Asia, there was a lot of community transmission. So the varying epidemiology of SARS-CoV-1 was always quite perplexing to me. But we certainly saw that evolution also with COVID-19, where we really saw it primarily as a community virus. And spread in the community, but also potential in the hospital. So it's a very interesting virus. In some research I had done around healthcare transmission of infections in healthcare workers. Many of my Denver Health nurses and physicians participated in that study about 10 years ago when we were looking for flu, but what we really saw with a lot of in the data was that most of the spread we were seeing actually we were detecting coronavirus, mini coronavirus outbreaks, and this is before COVID-19. But I think there is some propensity of coronavirus to these healthcare settings. Very speculative, but I still find it interesting. So that leads to my slide here, where I show a picture of visiting a hospital in Saudi Arabia. This is in Al Hassa, I believe, the picture on the left, and a patient who's recovering from MERS. And then the other three pictures are from SARS-1 in Toronto, where we just saw the healthcare setting really affected by this outbreak. It's still it was experiencing this outbreak as a healthcare worker was one of the more pivotal experiences in my career, along with SARS-CoV-2. So just some contrasts between SARS and MERS. Again, both coronaviruses, both are had some kind of bat reservoir, but just some differences in the intermediary host, one being maybe civet cats or raccoon dogs, and the other being camels. Very common in their mode of transmission, which was via respiratory droplets and probably some contact and airborne. And then the incubation period, very similar, wide range, can be short, can be kind of up to 14 days. And the syndromes were quite similar as well. And then throw in COVID-19. I don't have to talk to this audience about the clinical presentation, as I'm sure we've all had COVID-19 probably about 6 times each, right? So here we are again. Now COVID-19 is well established as part of our regular seasonal respiratory panel. And we see a lot of activity, and currently, right now as we speak, are having a bit of a surge of COVID-19 around the country. These are wastewater data, a new way of monitoring, or not so new, but a more common, increasingly common way of monitoring disease activity. And this is CDC data from the week ending September 6, 2025. We see moderate activity in Colorado, but high activity on the coast in Texas and California. And this will continue, I think, to follow that pattern where we have these surges of COVID-19 and then potentially followed by our seasonal flu surges. So it's here to stay. I think there's always the chance it could mutate itself out of existence, but that's not actually how it works. So this is a slide on coronavirus, or specifically the SARS-CoV-2. And you've heard since the beginning of the pandemic, we've had an evolution of different variants emerge. Our first one, which we call the Alpha variant, then we had Delta wave, we had Omicron, and there have been nameless others since then, including now, which is stealth or something like that. And these mutations happen, variants get selected. There's these mutations that just happen as part of the natural, very fast reproductive life of a virus. When you replicate in minutes, that can happen. And sometimes you get lucky. These mutations allow for some kind of antibody escape. And so then that mutation allows for a certain strain to become prevalent. And then as we either get a vaccine or natural immunity, then those variants go away, but a new one emerges. So this is just a cyclical pattern that we will continue to see with the coronavirus. Long COVID has been one of the big hazards coming out of a pandemic. There have been data associating COVID infections with a long-term, more serious illness. Wide range of ongoing symptoms that last weeks, maybe even years. Some describe brain fog, some describe neurological syndromes or immunologic syndromes. And the best way to prevent, at least as we know today, is to be vaccinated. And boosters are available to update vaccines as these new variants emerge. All right, now shifting to yet another emerging infectious disease that I've long found very interesting is dengue. And we've seen dengue fever reemerge in the US, in Texas, Arizona, California. And this slide happens to be from Arizona, where I gave a talk. So I think I focused on collating some data from that area. But we have seen, we know that this it's a specific mosquito that houses this, and so the Aedes aegypti is a mosquito that carries dengue. And as we go through climate change and other things that make the environment suitable for this mosquito, then with it comes the infectious disease. So this is again an old slide, but it's only one that showed this nice trend. But you can infer that past 2015, we've continued to see this rise. And largely, this is just global, and it's because it's been the mosquitoes have been able to encroach into more subtropical areas of the US and other places in the world. So this is a really neat graphic from Nature Microbiology that models out what we were seeing or what we knew from where we were seeing these mosquitoes living in the United States back in 2015. And so pretty confined to Southeast United States. But projecting forward, you can see how much that is expanding north, even some into, the Dakotas and Minnesota. And more higher activity in the areas where we know that it currently occurs. So, what is the clinical significance? Well, this is nobody wants dengue. This is one that you can get severe dengue. It can be life-threatening within hours, and 1 in 20 people develop severe dengue, and it can take on a hemorrhagic fever-like presentation. An estimated 40% of the world is at risk for this infection, and there are around 390 million infections a year. About 1 in 4 people infected will get really sick. So again, don't want it. Symptoms, typically, if you recover, you'll typically recover in a week. And so this schematic here shows some of the typical presentations, which include eye pain, headache, muscle pain, rash, bone pain, nausea, vomiting, joint pain. And so again, that sort of non-specific flu-like presentation. This is just a slide to show you there are dengue-like viruses out there. Zika was one that is also a new emerging or was a new emerging infection that I'm not going to have time to cover today, but is part of that same family. And then chikungunya, which is very much like dengue, maybe more confined to tropical regions of the planet right now, but very similar presentation. But much higher in the arthralgias than dengue. So we're going to shift gears to another emerging infection, and this is in the category of emerging infections due to loss of immunity. And this is the story of measles. Now, this headline was from 2019, before COVID, and before some of the recent changes that we've had in vaccine schedules in some parts of the United States. So we are in danger of losing measles-free status, which is an effect in part the anti-vax movement and maybe in part due to access to some of these vaccines and coverage schedules in some states in the country. This is a recent map, 2023, 2024, that shows measles, mumps, rubella vaccine coverage for kindergartners. And the important thing, this looks pretty good. There's a lot of orange on it, if or there's a lot of blue and light orange on this. You think, okay, well, that's not horrible. And the bar is high, 90% of above. But here's the problem. When you really need to have a high rate of vaccination in the community for a vaccine to truly have its maximal efficacy. You target 95%. The bar is set high if you truly want to eliminate an infectious disease. But once you get below that threshold of 95% and certainly 90%, then you are starting to lose herd immunity. And even people who are vaccinated, because there's more pressure from the circulation of these viruses around you, even those vaccinated become at higher risk of acquiring the infection that they've been vaccinated against. And then certainly those who are unvaccinated, they are at at increased risk, exponentially increased risk as well. So when we see these, states that are less than 90% in the dark orange, we need to really start worrying about that. And we're starting to see that happen. Now, if you were to look at this graph over time, going back to the 60s, these rates of measles would look tiny. But again, once you hit a certain threshold, there is a tipping point and it can really blossom and blow up these cases and make a lot of us at risk for getting this infection, particularly those who are unvaccinated or do not have the ability to mount an immune response to a vaccine because of an immunocompromised status, or can't get a vaccine because of an immunocompromised status. So this is something to really be aware of. The most recent cases in 2025 are shown on this graph, and I would say 1,500 measles cases in a vaccine preventable disease is far too many. So I want you all to know what measles looks like. Very few have seen it. I admit I did not see it during my training, but my little brother had this, and so I remember it as a kid. And there was a prodrome of fever, and they are high fevers in kids, often. We see malaise, cough, and coryza and conjunctivitis. And it used to be that we would say the three C's: cough, coryza, conjunctivitis. And then Koplik spots will come before a rash emerges, and there are these little white dots kind of opposite the molars that I'm trying to show on this slide here. And the old school docs will say this is a giveaway for measles. And the problem is measles is really transmissible before the rash appears. And the rash is what kind of makes it obvious. And so, oh, they have measles, they have a rash, let's, take them out of school. Well, by that time, that virus is already spread. So the rash appears 14 days after a person is exposed. The rash typically goes from head to the trunk to the lower extremities. And then again, you're contagious from about 4 days before that rash appears to 4 days after. So if you know that there's measles in a community, and you have this prodrome, and particularly if the kid is unvaccinated or the patient is unvaccinated, have a really heightened suspicion. Also understand that in a vaccinated population, we may see atypical presentations. So if it's not following the pattern exactly, it's something to be aware of and suspicious for. Mumps has also made some resurgences, and I just illustrate, have this case report from, and this trend from 2019 to share with you. It was a really interesting outbreak. I think this one was in Iowa, and many of the cases occurred in vaccinated individuals, again, because of that herd immunity issue. Um, and the prodrome here, low-grade fever, headache, malaise, myalgia. I think everything I've talked about today has that prodrome, right? It's hard to make these clinical distinctions. So unilateral or bilateral parotid, submandibular gland swelling, and then again, this is a cause of sterility, especially in boys, where after an orchitis. Uh, Infection or infection in the ovaries, it has a propensity to go in. And then also meningitis is common, so it can cause an aseptic meningitis. So here's a slide just sort of showing what we would consider acceptable presumptive evidence of immunity. And I think some of this has been changed recently, but typically we want to have a history of 2 doses of MMR. Healthcare workers really should have documented vaccination. And in an outbreak setting, it's typical that somebody born before 1957 would have had natural immunity, but you may not want to rely on that in an outbreak setting and get them vaccinated. So I'll end here. Again, we have to be aware of what is happening in the world around us. These infections can spread either because we bring them through transportation or that a new emerging infection comes because of climate change or any of the factors that I mentioned. And so keep heightened awareness of these potential infections. I'll conclude that we will continue to see these infections emerge, evolve. We need to have a high index of suspicion, keep your surveillance intact, and vaccinate where you can. So that's all I have, Ariana. And I think I have about 2 minutes for some questions, if there are any.
Great. Thank you so much. It was super informative. I know I learned some things. Does anyone have any questions for our presenter today?
Connie, I have a question for you. This is Heather. I wanted to get your thoughts on our H5N1 bird flu and how worried are you about this virus?
Yeah, I mean, I think we got to watch it. But right now it still is a low risk of human infections. There hasn't been a lot of human to human transmission. That said, it'll happen and we need to be prepared. So I think we focus on how we if there were serious cases, how we would handle them in a biocontainment environment. But right now, as I said, these have been more mild infections. And right now, I think that's not the biggest thing I'm concerned about. I'm way more concerned about measles.
Awesome, thank you.
Thanks, Dr. Young. Any other questions?
All right, I see some familiar places here, faces or names on the screen, not your faces, but I see the familiar names. So good to be in front of you all again. And it was a real pleasure to be able to be here. So thanks for inviting me.
Thanks
Take
so much
care.
for coming. Real treat to have you back. And yeah, just really appreciate you giving this great talk.
Great. Thanks, guys. Take
All
care.
right. Thanks, everyone. Have a great weekend. Bye.